let me introduce Andrew Tatarsky. You have his biography, so I'm not going to bother reading that to you. He's just one of the thought leaders, as you all know, in addiction psychotherapy and particularly harm reduction psychotherapy, and one of the true founders of that approach. So I'm sure we're all looking forward to hearing him. Andrew Tatarsky.
So it's a great pleasure to be here to set the stage for the day. Except now I have to find my PowerPoint presentation. But before let me do that. Okay. No. Is the tech person here who can help me find it? While we're waiting for that, I wanted to share something that's particularly special. In this past week, as I was preparing for my talk, it occurred to me that the division was founded in 1990, which is 25 years ago. So this is our 25-year birthday. And it was founded under the direction of Dr. Arnold Washington, who's sitting up here in the front. I was working with Arnold at the time at the Washington Institute, and Arnold had this brilliant idea to establish a division on addictions, and took the lead and inspired a group of people, including Debbie Rothschild, who's also here today and will be presenting. And that small group established the division, and we've been going strong for 25 years. So we owe, and I certainly owe, a lot of gratitude to Arnold for his leadership and actually bringing me into the field. So I'm going to set the stage by bringing you into what I've been struggling with for 35 years since I began to work with people with drug and alcohol issues. That is the complexities in the field. And we're calling this conference Dancing with Complexity, and I should say that over this past few months, as I've been dancing with these complexities, at times I feel like I've been wrestling with complexities. I've gotten lost in the complexities, confused, overwhelmed, and I hope what I share with you today doesn't put you in the same spaces that I've been in, but they may. And that's fine, because I think we need to really immerse ourselves in these complexities to try to come up with solutions for really the question of how can we as a field be more effective at helping more people who are struggling with addictive issues. Back a year or two ago at the Harvard Conference on Addictions, Ed Kansian made this statement. We must not look hard to see that we're losing the battle against addiction. It's a dramatic statement, but we also need to consider this as one of the facts. Over 100 people die of overdose in this country every day. And I just heard at a conference that in Ohio, 5 people a day are dying. So this is really an epidemic. And not to mention, most substance misusing people don't go to treatment. The treatment system is filled largely with mandated patients. Most who go to treatment don't complete. And most who go don't stop, or they switch to other addictions. For example, methadone maintenance patients who are being properly medicated for their opiate dependence frequently begin using all sorts of other substances. How do we understand the limitations of our effectiveness at helping this huge group of fellow citizens? And then let's consider that most substance misusing folks don't want to stop using. And they're engaging frequently in other problematic behaviors that you can't abstain from. This is an interesting statistic from the National Household Study that's done every year that found that of people who were determined to need treatment and want treatment, Close to 40% didn't access treatment because they didn't want to stop using. And most of us in the room probably know that the overwhelming majority of treatment in this country only offers abstinence as a goal. So that's one example of a limitation of the treatment system that doesn't really address this complexity. Now, this is a hard statement, but I heard Dr. Mark Willenbring, who's a former head of research at NIAAA, make this statement at a conference, that the addiction treatment system stinks. That's why most people don't go. Now, you know, I've been part of the system, and all of you have been for years, and you might feel offended by that statement. I feel a little offended, but I think we need to really look at, you know, what are we doing that's working, what are we doing that's not working, how can we be more effective at helping more people. I do think that most people with substance use issues are not offered appropriate treatment. And how can we make, this is really the challenge, I think, how can we make treatment more appealing? That is, so that people actually want to come for help. And I think that's our challenge as a field. Somebody once said, and I'm sorry that I can't remember who, but that if the treatment isn't more appealing than the problem behavior, why should somebody go to treatment? It made sense to me. But I want to suggest, and this is really what the focus of my talk is, it's about our models, our way of understanding. Models, paradigms shape our perceptions. They inform what we do. We all know that. But frequently, our models and paradigms are both explicit and implicit, conscious and unconscious. So we need to really be taking a close look at how we're thinking about addiction, about people that we call addicts. Tim Leary called this our reality tunnels. You know, back in the old days when we thought that the Earth was flat, people like Galileo were actually arrested for suggesting a new paradigm, that the Earth actually went around the sun. So I do think that we are in the midst, as Richard was saying, of a paradigm shift, a scientific revolution. We're moving from old ideas and old struggles in the field to attempting to come up with a new, more comprehensive model for understanding all of these complexities in addicted people that actually will lead to new, more effective treatments. I think our society is dominated by what I think of as an anti-meaning, one-size-fits-all, abstinence only. It's a very unitary view of this problem. And it's closely often linked to the moral and criminal models which preceded our disease model. You know, we can tell people they have the disease, but that then we blame them when they don't do what they're supposed to do or what we think they should do, as if it's their fault. And I'm wondering, what is it that we can do to, you know, to take responsibility for the failure? This model that infuses our culture informs a treatment system that is largely abstinence only, and all too often a mental health system that presumes that we cannot treat active drug users. The fact is, however, that most people struggling with substance use issues who become concerned about their use are active users who are not ready to stop. That's the majority of folks. And if a system doesn't actually have ways of meeting people there, it becomes irrelevant in a way. Now, there's another problem I've been really concerned about in the field. This problem of polarizing ideological battles. Different camps in the field are battling with one another. You know, addiction is a choice. It's not a disease. No, it's a disease. It's not a choice. We hear about AA bashers. Can you imagine people bashing a program that has helped millions and millions of people? But we also have AA ideologues who think that anything other than AA is enabling or is... I got a Facebook post from something that I put out there from somebody that said, if your treatment is not helping people have a spiritual reawakening, you're either not helping or you're going to help them to die. I mean, So these ideological battles, I think, are part of the problem. And let's think about the term addict. To many, addict is a dehumanizing social construct. It's an idea that we've constructed. And frequently, that word is loaded with all sorts of stigmatizing presumptions, consciously and unconsciously. Addicts are incapable of rational thought. They're powerless. They're selfish, self-centered, etc., etc. And this has been institutionalized in the past with statements like, keep it simple, stupid. Something that I once said to people back when I started in abstinence-based treatment, addicts suffer from the disease of terminal uniqueness. Take the cotton out of your ears, put it in your mouth. You know, we can see some truth in this and some value. But how much of the so-called addict's behavior is a self-fulfilling prophecy based on the internalization of this construction? Yet, on the other hand, some people actually find the addict identity affirming. One of the students in the class that we teach here, our certificate class on harm reduction psychotherapy, said he loves the identity of addict. He's found that to be really affirming of his experience. So this is really complicated. Here's a woman, Valerie, that I began working with about 4 years ago. I'm still working with her now. She came to me, a super mom with 2 young kids, president of the PTA. She reported to me she was injecting Dilaudid, a powerful prescription opiate, 4 to 5 times a day, and had been for several years. She told me that she only came to see me because she knew I wouldn't ask her to stop using. She said that she loved Dilaudid, didn't want to stop, and yet she was terrified of being found out, losing her children, creating crisis in her family. So she was really conflicted and tortured about this. But I did agree, after assessing for risk, that I thought she was a good candidate for psychotherapy. And as we began to explore the substance use, this history of trauma emerged. Sexual and physical abuse as a young child, sexual abuse as a teenager. She was raped as a young woman. And she had several treatment episodes which were also constituted what I have begun to think of as treatment trauma. One treatment rejected her from treatment because she was using drugs. That's an interesting complexity. So we worked through the trauma for several years until she became inspired and motivated to begin cutting back, and ultimately she detoxed, and now she's been on a very low dose of Suboxone for the last 2 years with an occasional drink every now and then. Incredibly stable. These are the kinds of patients that we see at our center every day. There are lots more, but I'm going to run. So I suggested that we're in the midst of this scientific revolution. I just talked about some of the more disturbing, frightening, and possibly depressing facts about what's happening right now. But I actually believe that this new emerging paradigm gives us reasons to be tremendously hopeful. And I think that we're in a very special moment in time where people from all different camps are beginning to recognize that we need to come together and create a more comprehensive model that really integrates the wisdom from all of these different traditions. And that's how I'm thinking about our challenge right now as a field. So we're moving from this old disease model based on Jelinek's famous paper based on a survey of AA members toward what I'm thinking of as a psychobiosocial model, which I'll come to. And we're moving from a categorical way of thinking about addiction, binary, either you have the disease or you don't, to a model that's more of a spectrum model, really a very different way of conceptualizing substance use problems on a continuum, which also has some complicated issues related to it. On the spectrum, we also have to consider that substance use problems and people with these issues vary on multiple dimensions. which I'll say a little bit about. So we're really talking about a new view of substance users and why people develop problematic relationships to substance use, and appropriate treatment that is implied by this new view. Let's get real basic. And this conference is about collaboration and consultation, so I thought it would be wonderful for me to actually consult with lots of my colleagues in the field to hear what they had to say. So I'm lucky enough to have relationships with a number of people who were good enough to send me their thoughts. And actually in my class we've also been debating whether addiction itself is even a meaningful or useful concept. But I checked in with William White, who is an AA scholar, wonderful person, and he said he would reduce addiction to its essential ingredients, which is compulsive drug seeking and drug using in spite of persistent consequences to self and others. Now, that seems to be a definition that most people kind of agree with, and I'm thinking of it as something about the experience and behavior that's related to the experience. Gabor Mate says craving, short-term relief, long-term negative consequences. Again, the inability to stop despite negative consequences. So we're talking about behavior and experience. And Bill Miller of motivational interviewing fame basically gives us the same definition. So it's interesting, people coming from different directions are really trying to make sense of a phenomenon, an experience, and related behaviors. Howard Josepher, who is a local guy who I think he would call himself an ex-addict. He's very open about that. He's the president and CEO of a wonderful program for ex-offenders called Exponents. He said, in less medical or psychological terms, as somebody who's had the lived experience, I see addiction as madness, a madness that justified irrational and at times bestial behavior. The madness was in truly believing that I needed to behave that way, and to do these things that on reflection were crazy. So we're talking about an experience and behavior that, as we all know, can be very, very frightening and very, very crazy and damaging. Some of my Facebook friends said, a relentless search for an altered, less painful reality. It was a temporary escape from life I really wished would just end. Then it became the way to escape withdrawals and maintain some strange kind of normality. Then it became a way to stay alive. I knew I was probably going to die. But none of that was necessary based on what I had been told. I believed I had to hit bottom. So here we hear precipitating vulnerabilities. We hear something happening over the course of that involvement with substances. We hear something about a social message that may play into that. So as I suggested, we're shifting from this binary model to continuum, earlier black or white views, in which we used to argue with people about whether they had the disease or not. We get into these ridiculous battles about, getting people to accept their disease. Now, as we see problematic substance use on a continuum, arguing about the disease misses the point. It's more relevant to ask in what way it affects your life, both positively and negatively. This really suggests a whole different way also of assessing, rather than do you have it or not. In what way does substance use infuse your life, impact maybe in a positive way, in a negative way? We can also now think about early intervention. We can think about moderate drinking limits. And the DSM-5 has codified this in their view of substance use disorders on a continuum, mild, moderate, severe. And there are different issues and challenges along that continuum. Now, Maya Solovitz, who's a very well-known health reporter, raised a real problem with this continuum view. She said, if we presume that substance use disorders are the disease, which is a dominant view, then as we identify some mild problems, does that mean that we're suggesting that they've got the early stages of this disease, which will inevitably progress? Another complexity. Or is it really useful to identify that binge drinking, for example, is a life-threatening behavior, in spite of the fact that it might not meet old abuse or dependence criteria? So how do we think about substance use on that continuum in a way that's most helpful? So Miller wrote this wonderful book in 2011, and he's got a great chapter, What is Addiction? If you want to read, he kind of goes through all of these issues in a very wonderful way. And he suggests these 7 dimensions. Of course, we can look at the pattern of use. We can look at the problems, the negative impact on one's life. We can look at physical adaptation. Is there tolerance, physiological dependence? Is there behavioral dependence? Are people relying on their substance as a coping strategy? Is there cognitive impairment, either that precipitated or results from it? Is there medical harm? And where are people in their motivation to change? These are all dimensions that are going to inform how we intervene. I would add, I have a psychoanalytically informed point of view, but that we also really need to be looking at the positive benefits, the positive functions, the meaning, and I'll be talking a bunch about that, the multiple personal and social meanings that substances take on for people. And also a dimension that I'm thinking of is awareness dissociation. And now I'm considering that we reintroduce the concept of the unconscious into our thinking, as I think it's a central idea that helps us to open up an exploration of meaning for people. And what causes addiction? Let's think about that together. Is it weak will, character defect, genetics, drugs, the devil? There are some religious people who believe that problematic drug use is demonic possession. Is it the environment? We've got this battle going on between the environmental social determinists, and the brain disease folks, as if they're, two separate causes. Addictive personality is a view that was more in vogue, I think, in the 60s and 70s, and led to treatments that were oriented toward breaking down the addict, breaking down the personality so that you could build them back up again. And I think that led to a lot of treatment trauma, which many of us in our practices see patients who experienced. And I think that's an important issue for us to be looking at. Or is anyone susceptible? I'm probably not going to be able to go through all of this in much depth, but let's just think about the different models. There's a personal responsibility model. That drug use, problematic drug use, is a violation of moral or religious standards. And there are people who believe that addiction is a choice. Jeffrey Shaler wrote a book about that, and Stephen Slater has a website where he talks about that. Addiction is a freely chosen behavior, he says. The desire can be altered by freely chosen behavior. No, I think I meant to write thoughts. And these folks believe that there's something liberating, something affirming about this point of view. That society is pathologizing choice behavior around substance use. Now, this can also lead to legislation, education, repentance, punishment, and I think it has contributed to our overemphasis on criminalization and stigmatization of drug users. Then there's the spiritual model. As we know, 12-step recovery is based on a notion that people are powerless without turning to a higher power. And many, many people have found that to be a tremendously life-affirming approach to recovery. But then we've got battles about the notion of powerlessness, and many other people find that that is it's a really problematic concept, and particularly for people that have experienced trauma or have experienced powerlessness in their lives. And some people on the extremes think that this is brainwashing, Although, as a good friend of mine said, who's in the program, many of us believe that we needed our brains to be washed. So, no. And there's this interesting set of ideas that are coming from different quarters on spirituality. Andrew Weil wrote a wonderful book in 1972 that humans have an innate desire or need for altered states, for transcendent states, and that may be a central source of the drug-seeking urge. And there's current psychedelic research going on at Johns Hopkins and other places, which is finding that if you can help somebody have a spiritual experience, a transcendent experience, that is associated with long-term positive benefits to quality of life, a sense of connectedness with others. So spirituality is now being looked at from a research point of view, and there's increasing evidence to support that as a factor in positive change. The disease model pervades our culture. The old disease model, Jelinek's model, was a basic narrative that addiction is permanent, chronic, progressive, only arrested by complete and total abstinence, and that gave rise to the contemporary addiction treatment scene. I think it's not supported by evidence from a number of different points of view, least of which is that the majority of people struggling with substance use issues don't find that approach to be terribly useful. Abstinence only limits who can come into treatment. Abstinence-based treatments are certainly very relevant and helpful to people who embrace it. So we're talking about the abstinence-only limitation. Now, just to think a little bit about the brain disease idea, which is now what NIDA is researching, I checked in with Nora Vokal, who was out of town, and she suggested that Ruben Baylor, who is a close colleague of her, respond to me. And he said, quote, "Addiction is a chronic but treatable brain disorder. People who are addicted cannot control their need for alcohol or other drugs, even in the face of negative consequences. And the lack of control is the result of alcohol or drug-induced changes in the brain." So he's very much focusing on the impact that drug use has on brain function. On the other hand, actually I poked around a little bit at his writings, and he has another publication somewhere that's looking at the interaction between belief and brain chemistry, and he's finding that belief has a profound impact. So outside of this context, he's also interested in the psychological dimension. And similarly, Alan Leshner, who was the person who was the head of NIDA who really put forward the brain disease idea, said he was talking even back in 2001 that there's this overly polarizing tendency that surrounds the brain disease idea. He says, "A century of psychobiological research has taught us never to put biology against behavior. We've finally learned that we don't have to separate minds and biology." And this is really a position that contemporary biologists take. They're talking about body-mind. That, and my view of psychobio is that we don't have the science to be able to tease apart how much is bio and how much is psycho. So we need to be considering always both in our attempts to understand human behavior and experience. Then we've got wonderful learning models. Here's Molly, as a patient of mine. She said, "I began to drink at a young age. I never developed good coping skills. Drinking was my coping mechanism for years. It was relatively easy to break the physical addiction, but it took time to develop positive coping skills, trust, real friends. In short, I think addiction is a maladaptive coping behavior." And Alan Marlatt and his colleagues who developed relapse prevention have talked about addiction or addictive behavior as overlearned habits based on classical and operant conditioning, modeling from substance-using folks in your family, in the community, expectancies. He did some wonderful research in his bar lab showing that when you give people beer in the lab, they get drunk, even if it's non-alcoholic beer. It's really interesting research. That's the expectancy, the power of what we believe. And I've thought that biology, meaning, habit, and social context converge in this conditioned urge, that they're all living together in that urge. And therefore, the urge I think of as an axis of change. If we can help people develop a capacity to sit with their urges and open up an exploration of the various factors that are contributing to that experience, it then becomes possible to think about change. And urge surfing is a technique that Alan Marlatt introduced into the field to help us do that. Now we can move to meaning. So we're talking about biology, habit, conditioning, and meaning. I believe that we need to also consider that substance use carries multiple personal and social meanings. Some of them are in people's awareness, some are out of awareness, dissociated, and we might consider that the problem behavior for many people who have experienced trauma and have dissociated experiences, the problem behavior is like a language. It's a way in which dissociated parts of the self find expression. Leon Wormser wrote a wonderful book called The Hidden Dimension in 1977 that really opens up this exploration. And Stanton Peele wrote a book in 1985 called The Meaning of Addiction, which really introduces and affirms the... Oh, I said 1885. I don't think he's that old. Sorry, Stanton. So from the meaning point of view, the addictive relationship both expresses and disguises dissociated meaning and parts of the self. And to the extent that that is true, the problem behavior can be the entry point for the process of rediscovering and integrating disowned parts of the self. Now, some of you people may think I'm crazy, but just briefly I'll share a kind of experience that I've had repeated many, many times. When I'm working with a patient and helping them develop skills and capacities to sit with their urges and surf the urge, we can then move into what we call unwrapping the urge, asking the urge if there's thoughts, if there's feelings, if there's memories, if there are things that the urge has to say. And very frequently people spontaneously report, for example, with one patient, yes, this is the traumatized 4-year-old little girl that was kicked down the steps by my dad. And those memories begin spilling out. Or another patient reported a memory of being thrown into a pile of bicycles when he was 7 by his schizophrenic mother. So moving into the urge, these memories and thoughts begin to occur. Or sometimes people feel incredibly triggered and feel like they need to, get loaded. And if we can help them sit still and unpack the urge, people then begin to get in touch with feelings. And frequently, when the feelings come into awareness, the urges pass. So clearly, the urge is a powerful bio-behavioral experience that seems related to history and trauma. That's really interesting to me. Ed Kansian talked about addictions. He thinks of them as disorders of self-regulation and that they're rooted in human suffering. Addictive behavior becomes compelling, and here you'll hear, similar to the other definitions, susceptible individuals discover that addictive substances offer short-term relief, change feelings that can be extreme, overwhelming, and intolerable. And this dimension of intolerable distress, intolerable pain, intolerable feeling seems to be a core part of most of our patients' experience. This desperation which leads to the felt need to take a drug to shift the mood, despite the fact that there may be very long-term, very negative consequences. And added in another publication, to understand and be understood is a powerful antidote to the confusion, chaos, and suffering associated with addictions. Ed also talked about self-medication. He talked about drug use as an adaptive attempt to repair personality difficulties in affect management, self-esteem, interpersonal problems. We also see, and I have a chapter in my book where I wrote about this, substance use as a rebellion against the inner critic. Many of our patients will report they live with powerful, punitive, attacking inner critics that create tremendous anxiety and tremendous despair and depression when people fail to live up to standards. And one good way that a psychoanalyst once taught us, Fenichel, to put the superego to sleep is to get drunk. He says the superego is that part of the personality that is dissolved in alcohol. I can just be myself. You know, I can express all of those parts of me. However, the next day the critic is waiting to attack depression, suicidality. So we tend to think about the biological aspect of what creates the post-binge depression. Let's also consider this psychological dimension. Substances can also be interpersonal communication. You know, the screw you drunk. You know, but then you could say, it wasn't me. I didn't, you know, I got drunk. That's why I didn't call. So parts of the self and feelings can be communicated in action when they can't be communicated in words. And, of course, we have to add trauma into the mix. There are so many increasing studies that offer powerful evidence that trauma is related, that is early trauma, developmental trauma, and even, you know, trauma in later life is associated with problematic substance use. One of these studies, for those that are not aware, is the Adverse Childhood Experiences research. They found, looking at a number of different adverse childhood experiences, the more that were present in early life, the greater the likelihood of problematic substance use, early smoking, sexual promiscuity, health issues. I mean, it's just incredible to look at those data. Up to 50% of all people that seek substance use treatment suffer PTSD. Van der Kolk's found that says a maltreated child is up to 12 times more likely to develop addiction. And this, on the bottom, is just incredible to me. You know, the higher rates of partner abuse in addicted women. Oh, and rates of sexual abuse. Najovitz found that up to 85% of women with significant substance use have histories of early sexual abuse. That is mind-boggling to me. So I've been thinking, at times, it looks like addiction is a trauma-related disorder, a response to trauma. On the other hand, there are lots of folks that have significant addictions where we can't find histories of significant trauma. So there's another complexity. Jen Talley, my colleague at the center, gave me this slide. 80 to 95% of those in treatment for addiction have a history of trauma, according to Brown et al. So trauma. And this is one way that I think that trauma has an impact. Trauma is typically dealt with by dissociation, that is splitting off from parts of the self, from feelings that were related to the trauma experience. That in turn contributes to difficulties in developing capacities to self-regulate, to regulate feeling states. So people experience deadness or feeling flooded by feelings. And there's also mistrust, interpersonal mistrust, and feelings of shame and self-hate, all of which represent tremendous vulnerability to addiction or to using substances to self-medicate the symptoms. Now, substances can also be a place where these split off, dissociated parts of the self live. I've often thought about, where do these vital parts of the self go? You know, the rage, the grief, the sexuality, the playfulness, the things that were not accepted or were punished or shamed in my family, in my culture. They go as Eminem, the songwriter, wrote a song about cleaning out his closet. You know, they go into the closet. They get suppressed, they get repressed, they get dissociated. And they frequently find a way out in addictive behavior, and people often feel that they can temporarily reconnect with those parts of themselves, which may be why going back there again and again feels so compelling and so vital. And why a demand for somebody to stop their substance use might feel to some people like a death sentence. Like, you're actually wanting me to kill off a part of myself, and that's a statement that patients have made. And finally, let's look at relational meaning. Debbie Rothschild has written a number of wonderful papers about a relational harm reduction psychotherapy. Lisa Director says it really beautifully in a paper of hers that chronic substance use is seen as being driven by conflicting and unresolved relational dynamics that derive from early organizing relationships in a person's life. In terms of this conflict, or the terms find concrete expression in characteristic acts of drug use that serve to perpetuate it. So relational dynamics live in the relationship to the substance and also get expressed relationally. I go to the substance rather than to people who care about me. There's a relational dimension to that. And when I can't, tolerate a feeling of distress, I feel so profoundly ashamed of it that I can't turn to anyone for help. I go to the substance. So that relational dimension then enters into our therapies, and that's where a relational psychotherapy becomes so critical. 5 minutes? Uh-oh. Uh-oh. So we can't talk about the social determinants, except that I want to say there's so much research that shows that social determinants have a critical impact on people's vulnerability to use substances and also engage in risky behavior around the substances. This is my way of putting all of this complexity together, what I call the psychobiosocial process model, where we can consider that a number of these factors we've talked about constitute vulnerabilities. None of them cause addiction. Genetics don't cause addiction. Trauma doesn't cause addiction. But there's some mix of factors that is unique to each person that represents a high vulnerability to use a substance and find that it fits, it helps, it's rewarding, it gives me relief in some way. And as people begin to use, there are psychobiosocial consequences that follow from that, which intensify the desire. So to the extent that we now can consider that there are multiple factors that are getting expressed in problematic substance use, we now can intervene anywhere in the process, even if the person isn't ready to stop using. And that helps us understand why so many people might be in pre-contemplation, contemplation, or preparation phases, the majority of people in our clinical population, not ready to stop using, but really needing to figure it out. And therefore, we need to be dealing with substance use and all of these co-occurring issues in the same therapy. We need an integrative treatment. Vulnerabilities and consequences frequently need to be identified before or in the course of addressing the problematic substance use. And we can work with people even if they're not ready, willing, or able to address the substance use directly. Okay. I want to take a minute to talk about integrative harm reduction psychotherapy and then just close with some final thoughts. So this is my attempt to map a psychotherapy that integrates all of these different perspectives. It seems to me the critical piece that we need to be thinking about as the foundation for all of our work is the therapeutic alliance. And the harm reduction frame, which is essentially about starting where people are, is a framework that enables us to work collaboratively with people to figure out a way to create an alliance that will actually encourage them to enter into treatment. So that's our challenge, creating therapeutic alliance. Then we have a relationship that develops that's going to be highly personally negotiated between each therapist and patient, again, addressing the particular needs vulnerabilities, unique characteristics of each person. We also need to be thinking about enhancing self-management skills if we consider that self-regulation is a critical vulnerability for many people, and that then together we can engage in what Pat Denning, another harm reduction writer, has called assessment as treatment. We can collaboratively work to identify all of these various factors, and including the ambivalence about change because of the investment in the problem behavior. Out of that exploration, we can start talking about goals that are highly personalized for each patient and a treatment approach that will be tailored to each individual patient. So we're moving from one size fits all back to a highly individualized, personalized, integrative approach. Final thoughts. I think I've implied, I think addiction is personal, it is social, and it is political. You know, as long as we are criminalizing drug use rather than treating it as a health issue, we've got a big problem on our hands. And if we start treating drug use as the health issue that it is, we've got lots of money we've been devoting to prisons that we can put into treatment. And we can fund our treatment system, we can train our staff, and we can offer people high-quality, harm reduction-informed treatment on demand, regardless of people's ability to pay. And I think that's got to be part of our drug policy reform and treatment reform efforts. And finally, we can help unique, complex people, not brains. We treat people, we don't treat brains. Let's treat them as such and support them in finding their ideal path to healing, growth, and positive change. Thank you.